Pregnancy. We'll be looking at fertilization, we'll be looking at implantation and early placental development. Remember, with fertilization is the union of the ovum and the sperm. You can see that in the picture right here. It's the union of the ovum and the spermatozoa, and it occurs about 24 hours after ovulation. So the ovary will ovulate, or the client will ovulate, and fertilization usually occurs at about 24 hours after ovulation, and usually occurs in the outer third of the fallopian tube. So these are fallopian tubes. So fertilization should occur at about this area. And then after with the egg, or the fertilized egg, will travel down the fallopian tube and burrow deep into the lining of the uterus at about this area on the upper part of the uterus, usually about 1 week after fertilization. So that's what we refer to as implantation. And then we begin to witness early placental development. You begin to see a combination of the endometrium of the uterus and the fetal chorionic layer. So the maternal and embryonic parts begin to fuse or combine. The chorion begins to produce human chorionic gonadotrophin. And then there's transmission of nutrients from the maternal bloodstream by a number of mechanisms. There's also transfer of oxygen from the mother to the fetus by diffusion. And also, there's also removal of waste products of fetal metabolism into the maternal bloodstream from which they are excreted. In terms of assessment of pregnancy, one way to assess pregnancy could be using the estimated date of birth, your EDB, and we can use the Naegele's rule. To calculate this, you'll need to count back 3 months from the first day of the last menstrual period of our LMP, the first day of our LMP. So you want to count back 3 months from the first day of our LMP, and then you want to add 7 days and 1 year. So that's how to use the Naegele's rule. Again, we can also assess pregnancy using an ultrasonography, and this would estimate the fetal age from head measurements. We could also assess pregnancy from the fundal heights. Here we are trying to measure from the top of the symphysis pubis. So from the top of the symphysis pubis to the top of the fundus. You will feel it, it will feel like a flexible, you'll need to get a tape rule. So that's what you want to use and measure from the top of the symphysis pubis to the top of the fundus. So if it's about the level of the symphysis pubis, that'll be between 12 and 14 weeks. That will be your estimation. Is between 12 and 14 weeks. If your measurement is at about the level of the symphysis pubis. If it's at the level of the umbilicus or at about 20 cm on your tape rule, that tells you your pregnancy should be estimated at about 20 weeks. So 20 cm, 20 weeks. And subsequently, it should rise at about 1 cm every week until the 36th week, after which it could vary. So at the level of the symphysis pubis, it's between 12 and 14 weeks. At the level of the umbilicus, or the 20 cm mark on your tape, is about 20 weeks, and then subsequently 1 cm every week. In terms of obstetric classification, you want to classify the mother as either a gravida. Gravida, you are looking at the total number of pregnancies, regardless of duration, and it also includes the present pregnancy. So you want to know the total number of pregnancies, regardless of duration, inclusive of the present pregnancy. She could also be nulligravida, which is a woman who has never been pregnant. Again, you also want to know what para is and how you can use that to in obstetric classification. Para would be the number of past pregnancies that have gone beyond the period of viability. So that's what you classify as para 1, para 2, and all of that. So the period of viability is that period or the capability of the fetus to survive outside of the uterus. That's usually after 20 weeks gestation or greater than, if the infant's weight is greater than 500 grams. So regardless of the number of fetuses, whether it's a twin pregnancy or it's a single pregnancy, is categorized as 1. And again, you also want to consider whether the infant was born alive or dead. Okay, so for para, is the number of pregnancies that have gone beyond the period of viability, regardless of the number of fetuses or whether the infant was born alive or dead. So if it's a twin pregnancy, it's classified as 1 para. If it's how many pregnancies has she had that has gone beyond that period of past the 20 weeks gestation or greater than 500 grams, you want to capture that. And again, it's whether the infant was born alive or dead is still categorized as para. Term pregnancy would be any infant born from beginning of the 38th to the end of the 42nd week. And abortion would be any pregnancy that terminates before the period of viability. In terms of characteristics finding, what would you see with pregnancy? Well, the uterus increases in size, and it's about, or it's above it rises above the symphysis pubis at about 12 to 14 weeks. Another characteristic finding you would say would be in the cervix. The cervix begins to soften. You would notice a mucus plug in the canal, and you also notice the cervix begins to appear bluish in color. And this bluish color is what is referred to as our Chadwick sign. So that's the cervix, and you can see that bluish coloration. With the abdomen, you begin to notice some stretches and also striae. The breast becomes enlarged and they become tender. With pregnancy, the blood volume increases 30% and usually peaks at about 28 weeks. The cardiac output also increases by 70 mil per minute. So there's an increased cardiac output. And in terms of ventilation and digestion, there's decreased tidal volume, especially in the 3rd trimester. And with digestion, there's also decreased peristalsis and increased pressure. On the skin, we would notice pink or reddish streaks, which we refer to as the striae gravidarum. You will notice these pink or reddish streaks on the breast. You will see them on the abdomen, on the buttocks, or the thighs. These are as a result of fat deposits that are causing the skin to stretch. So you're going to see that on the breast, on the abdomen, on the buttocks, and the thighs. There's also going to be increased pigmentation on the face. So you have these blotchy brown areas on the forehead and the cheeks. They're actually referred to as chloasma or marks of pregnancy. So you will see that on the face, these blotchy brown areas. So that's referred to as chloasma or marks of pregnancy. You also see a dark line from the umbilicus to the symphysis pubis. So we can see that here. These are linear nigra. You would also notice some minute vascular spiders. So these are our minute vascular spiders or spider angioma or spider telangiectasia. So this is it. You will notice this. This is a vascular lesion that contains red spots and reddish extensions which radiate outward like a spider's web. So that's why it's called vascular spiders. The umbilicus is usually pushed outward, and by the 7th month, the depression disappears and it becomes a darkened area on the abdominal wall. So that's one of the findings you will see on the skin with pregnancy. And finally, the sweat and sebaceous glands become more active. With the urinary system, there's going to be frequency of urination and stasis as a result from the pressure of the pregnancy. In the endocrine system, the placenta begins to produce estrogen, progesterone, the human chorionic gonadotrophin, and also the human placental lactogen hormones. Remember, the estrogen helps with maintenance of the female reproductive structures. It also stimulates the growth of the uterine lining. Even the progesterone helps also to maintain uterine lining for pregnancy. The human placental lactogen is also a hormone that's released by the placenta during pregnancy. So as the fetus grows, the HPL levels gradually rise, and after the pregnancy, these levels will drop. Also, the HCG is actually a hormone for the maternal recognition of pregnancy. It's actually produced by the trophoblast cells that are surrounding a growing embryo, which actually or eventually forms the placenta after implantation. We would also have the pituitary. With pituitary, there will be elevated estrogen and progesterone levels. And there's also suppression of the luteinizing hormone, which is supposed to induce ovulation. But if the client is already pregnant, then we don't need the luteinizing hormone. So this will be suppressed. There will also be suppression of the follicle stimulating hormone, your FSH. Remember, the follicle stimulating hormone regulates egg production in the ovaries. So this would also be suppressed. And again, oxytocin would also be suppressed. Oxytocin is usually produced in the hypothalamus and is released by the posterior pituitary. It plays a role in social bonding, reproduction, childbirth, and the period after childbirth. It's actually called the love drug. It's released into the bloodstream in response to love and in labor. Again, there would also be weight gain. Steady, consistent weight gain is ideal. Again, it's also the weight gain is based on pre-pregnancy BMI. For example, if the client's BMI is less than 18.5, the total weight gain range should be between 28 and 40 pounds. If her BMI is greater than 30, then her weight gain or the total weight gain should be between 11 to 20 pounds. We can we can measure our HCG by radioimmunoassay in the blood or in the urine. The serum actually is more sensitive, so results are more accurate and available earlier with this test. So that's one diagnostic test for pregnancy by measuring serum HCG. Again, in terms of verifying pregnancy, we have the presumptive tests for pregnancy. Those are changes that are felt by the woman. For example, the amenorrhea, the nausea and vomiting, which is your morning sickness, breast sensitivity, fatigue, quickening. Quickening is that maternal perception of fetal movement occurring between the 16th and the 20th weeks of pregnancy. Again, another presumptive sign would be urinary frequency. So these are the changes that are felt by the woman. We have the probable signs of pregnancy. We're looking at is probable. What's the probability that she's pregnant? You want to see changes. So these are changes that are observed by the examiner. You see the uterine is enlarged. There's uterine enlargement that tells you probably this lady is pregnant. There will be contractions and SOFU. That's also a probable sign. Again, we might see positive urine pregnancy tests. Remember, it could be positive, false positive and all of that. So it's still probable. It's still a probable sign. And again, you will also notice Hegar's sign. Hegar's sign will be the softening and compressibility of the isthmus of the uterus. So this could be noticed by the examiner. On examination, you will notice that there's softening of the isthmus of the uterus. So if you do a V, you'll be able to determine this, but again, it's still a probable sign. We'll also see Chadwick's sign, which is that bluish discoloration of the cervix. That's also still a probable sign. And then we also have the positive signs, undisputable signs. For example, these are your fetal heartbeats. You can use a dub tone to hear the fetal heartbeat. So you can use a dub tone between 8 to 12 weeks. We can use auscultation and hear the fetal heart tone between 18 to 20 weeks. So this is a definite sign of pregnancy if you can hear those fetal heartbeats. Again, palpation of fetal movements. You can actually feel for fetal movement. That's a positive sign of pregnancy. Finally, visualization of the fetus by ultrasound. You can see it, so it's there. That's a positive sign of pregnancy. In terms of fetal assessment, a significant predictor of fetal well-being would be a fetal heart rate of 120 to 160 beats per minute at term. So you want to assess, and that's the rate we want the heart to be at. You can also assess fetal movement. So you want to see a regular pattern of 10 movements in 1 hour, at least twice a day. That's a good indicator of fetal well-being. If you have fewer than 3 movements in a 1 hour period, that should be reported. So finally, let's look at some discomforts of pregnancy. There's going to be that morning sickness. And again, this may occur at any time of the day. You want to give the client dry crackers on arising from bed. You want to eat small, frequent meals and avoid strong odors and greasy food. Another discomfort will be the constipation and the hemorrhoids. So you want to encourage regularity and routine in terms of evacuation of our balls, generous fluid intake, bulk foods, fibers, and stool softeners to help the stool get soft. Leg cramps is also another discomfort of pregnancy. You want to dorsiflex the feet, apply local heat, also increase her calcium intake. So for breast soreness, you need to advise the client to wear well-fitting bra, and also she can wear this bra at night for comfort. With backache, you want to emphasize posture and good body mechanics, careful lifting of objects. Don't wear high-heeled shoes. And again, pelvic tilt exercises can be engaged in to help with the backache. With the heartburn, you want to give small frequent meals, avoid antacids, especially those that contain phosphorus. So she can use antacids, but she needs to avoid those that contain phosphorus. Again, you want to decrease fatty and fried foods. These would not be good for firstborn, so she needs to decrease them and avoid supine position after meals. With dizziness, she needs to be taught to slowly rise from bed, make deliberate movements. You can also give her support stockings, and you also want to monitor her intake. With the vertigo and the lightheadedness, you need to teach her to turn on left side. You also need to educate her on maternal hypertensive syndrome, or what we refer to as supine hypertensive syndrome or compression syndrome. This is caused when the gravid uterus compresses the inferior vena cava. So the inferior vena cava and the aorta is compressed by the fetus when the lady or the mother lies supine. Okay. But again, you can see the compression is relieved by tilting the patient on the left side. So the weight is off the inferior vena cava. So you need to educate on this. And finally, you need to teach Kegel exercises, decrease fluids before bed, and also report signs of infection. So all of this is geared towards urinary frequency discomfort in your clients.